Thank you very much. Now let's get to start our discussion. And we have a number of people, experts, who will assist us to look at the issues that we have to deal for you today. Now, here in the studio, I have Prosper Bani, who is chairman of the NDC's technical COVID-19 team. Good morning, and thank you for joining us, sir.
Good morning.
Great.
Happy to be here.
We also have here Kweku Kwarteng, his MP of Boise West and Deputy Minister of Finance. Thanks for making time, sir.
Thank you, too.
Right. On Zoom, we have Dr. John Amwesi, his lecturer, Global Health Department, School of Public Health, KNUST, and leader Global Health and Infectious Diseases Research Group at the Kumasi Center for Collaborative Research in Tropical Medicine, KCCR. Thank you, Dr. John Amwesi, for making time once again. Okay. On Zoom also is Nana Kofi Kwache, Research Fellow, Doctoral Candidate, and Adjunct Assistant Professor at New York University School of Global Public Health Studies. He studies health systems, health services, and health economics with a special focus on provider payment mechanisms and equity in access to care. Thank you very much for joining us, Kofi.
Thank you, Samson. Great to be here.
Good to have you. All right. So, shall we begin? And gentlemen, particularly those of you who are the experts, and I'm talking about Kofi and John, by the time we are done, we will need you to educate us on your mask wearing protocol. When do we wear the mask? When do we not need it, maybe, and how do we wear it? How do you do it yourself, and why do you do it the way you do it? So that we can help a lot more people to follow the protocols. Now, as you know, if you go to the Ghana Health Service website, something happened yesterday and took our numbers, infection numbers, dramatically high up to 4,012. 4,012. Ghana's total count of confirmed COVID-19 cases from the 12th of March to 17th May 2020 to 7th May 2020 stands at 4,012. A total of 18 deaths have been recorded for the same period. In addition, there have been a total of 323 recoveries. Ghana's cases under care, that is active cases, as of 7th May 2020 stands at 3,671. Between the last update on the 4th of May 2020 and the current update, a total of 921 additional cases have been recorded. Over 50% of these cases were as a result of an outbreak in an industrial facility with 1,300 workers, of which 533 have been confirmed positive. Over the same period, 20 more recoveries have been reported. Borno region has recorded a case, and thus 13 out of 16 regions have reported cases. Currently, the only regions with no confirmed cases of COVID-19 are the Savannah, Borno East, and Ahafo regions. Right. So let's get to the focus. Let me start with Mr. Prosper Bani. From where you sit as the team that has been put together by your party, what do you say about Ghana's management of COVID-19 pandemic so far?
Thank you very much, and I'm happy to be here this morning to discuss this topical issue of how we are managing COVID-19 in Ghana. I would like to stay up front that we can do better. The management of this pandemic in Ghana can be structured better, can be managed better, can be can transmit information to the population better, and can mobilize the citizens to become more conscious and be more receptive to some of the directives that the leadership has put in place. I'm saying this because since the first two cases on the 12th of March, there has been a lot of actions and directives from government. First of all, the closure of the border was delayed, which opened up space for a lot more people who had been infected from other jurisdictions to come into Ghana. Obviously, we all are aware about the processes that took place, the quarantines, the testing, and subsequently the contact tracing. At that point, all managers of crisis of this nature will have begun to project the manner in which these cases will increase. We didn't see any of those projections. But some experts even at that point, could tell us that we will be having very sharp increases if the right measures were not taken. Indeed, government decided after 2 weeks to put in place a lockdown. Lockdown accompanied with certain measures, i.e. Restrictions on gathering, not more than 25. We also had the protocols of washing of hands, no touching of face. Churches were asked to suspend their activities. We went through, indeed, Easter without the Christian population celebrating the death and resurrection of Christ. Today, we have the Muslims going through their Islamic fasting and processes, and we also have their day of celebration after the fasting. We are still under a process of managing this COVID-19. As we speak, from the 12th of March to today, you could see the rate of increase of the numbers as we go along. Initially, the epicenter was only restricted to Accra and Kumasi and Tema and Kaswa environs. Today, it has gone up to the northern sector of this country, it's gone to the Volta region, to the Oti region, and those numbers are having significant increases. This is because something is not going right. And the message that is coming out from leadership is that there is full control on the cases in Ghana. This, I think, is not entirely correct. And there are several concerns also about the way the numbers are being churned out to the population. Most people who are critical observers of this process have doubts on the cases that are being announced. Citizens must have trust in the managers of this pandemic. That is the number one criteria for success in any crisis condition. Indeed, I've had time to comment and made my point very clear that we need to elevate the management of this process from a task force committee approach to a crisis management approach with a clear command structure as in other jurisdictions. This crisis is going to be with us for the long haul. Indeed, the last broadcast of the president, he was noted for the first time to have described the situation as a warlike situation. A warlike situation needs a warlike response. There is no two ways about it. Granted that we don't have the military in any battle with anybody, but the pandemic, if you consider it as an enemy force, you need to design a structure, a strategy, you need to design a plan, you need to put together capacities, you need to identify your frontline workers, you need to define all these all these categories of persons, institutions, and facilities that will confront the pandemic. As we speak today, if you ask where is the plan, where is the strategy for executing this fight against COVID-19, we are yet to see any document. There cannot be any consistent, strategic, tactical approach to address this if you do not have a plan or a strategy. Secondly, on this one, on the management of the cases, we also need to have a clear definition of the crisis management team. It cannot be a fluid team. People can go in and out, but we need to have a clear structure. We need to know who is in charge. That when we hear that voice, either early in the morning or early in the evening, we know we are getting the correct and accurate figures. We know we are getting the correct analysis of the data. We know we are getting the correct impact on COVID-19, on our people, the economy, social life, and how it's disrupting our cultural settings. We need to know the response approach. These are not normal times, and therefore we cannot have normal responses. Indeed, any approach, in fact, I've just touched my face mask, which is not proper. Indeed, any approach in addressing the economy cannot be addressed as though we are in normal times. I've had time to comment on how we need to have a targeted, a critical economic response approach to abnormal situation in this our country. We cannot have a copycat approach to economic recovery or economic development, as the case may be, or the management of some financial figures as a way of responding to this crisis. We need to have a transparent, accurate data and all the inflows in terms of resources coming into this country to respond to the crisis. We need to have some transparency in how this is managed. This is a crisis management situation. We cannot go on without transparency, timely, accurate information to the citizens to make sure that the citizens follow.
Is it your background with the United Nations in dealing with, as it were, peace-building development that you are talking about, a war sort of approach, or it is the science and the data as we have become, familiar with using, that you are basing the statements that you make here on? For example, I think a very critical point you make is that we can do better. Then you proceed to say there is no plan. Is it really the case that there is no plan, or that you have not looked to see that there is plan? And you have not heard the president consistently refer to the strategy, the plan, as it were. On the basis of Ghana's plan, the United Nations the World Health Organization has put Ghana 6th among countries that are effective in COVID-19 management. What do you say about that?
Well, let me correct you about my background. My background is not limited to conflict issues and peace building at all. My last management position in the United Nations, I was the director for Africa for crisis prevention and recovery. Crisis prevention means all manner of crises: drought, floods, health, earthquakes, every crisis that was expected, including pandemic.
Is it possible for Ghana not to have a plan, not to have a strategy, and yet to have the World Health Organization score it such high marks globally for being 6th among the countries that have effective means of checking coronavirus or managing it?
Well, my question to you and your viewers is, have you seen the plan? Have you seen the strategy? In every jurisdiction,
there is enhanced testing that has been going on. There is the increase in the laboratories that have been doing the testing. The president continues with the refrain that we will also test and do a lot of the tests to ensure that we are containing this. You don't see that's the strategy?
In every jurisdiction, and any response plan or a strategy can be assessed. You have to touch it, you have to read it, and comment on it if necessary. If in a global meeting, which I've participated in severally, you present what you are doing at a meeting, very impressive, the meeting could immediately score you very high. It's done. Whether we are making sure that people wearing masks today are complying to the wearing of masks, it's another issue. Regularly, as I observe these protocols and observe others are trying to adhere to the protocol, it is very disheartening that our citizens do not appreciate or understand, or not conscious of what the protocols means. Yesterday, about 80% of persons are met wearing the mask, had the mask below their mouth. And I had the opportunity to ask a couple of people. They say, oh, they cannot breathe. They don't understand what's going on. That when they get into the shop, they'll put it across their mouth. Is that the
same as not having a plan and not having a strategy? Well, if you do not have a plan, I doubt that from the very first onset, when the outbreak, the WHO announced and declared coronavirus as a pandemic, we issued, through the health minister, issued EI 61, also affirming and declaring it as such to begin our preparedness. Then we had an EI 62, we had EI 63, we have had 64, now we are around EI 68 or so. Now, for almost all the 8 EIs, don't you see a certain graduated, deliberate strategy and plan, including border closures and extension of the closures, the measures that were announced through EI 64 and the 67, also going ahead to, as it were, continue with the extension. And we're expecting that tomorrow, if the president addresses the nation, we'll be told about a next EI that may come out. Don't you see a certain strategy that is unfolding? The stimulus packages, everything that has happened so far.
I don't see it. What I'm asking for is the plan.
You don't see what?
I don't see. Where's the plan? Did you bring a copy of the plan?
I'll come to you.
If you brought a copy of the plan, I'm happy to say it and to acknowledge that there's a plan. We have asked for a plan. If you want to collaborate with government, we'll have to collaborate with government based on a plan that the government is following, and then we can collaborate with the government. But if there's no plan and every week you pronounce directives, and every week the directive changes based on what you are observing or experiencing, that for me, with my long experience in managing programs, cannot be a plan. we can have the government knows what a plan is. If they don't have one now because of certain reasons, let us agree on that. But if you say you have a plan based on weekly directives, I'm afraid from where I'm coming from, I cannot hold it and say this is a plan or this is a strategy. I am happy to work based on the weekly directives.
So the team that you work with as the NDC's COVID-19 team, I've seen very respected people, including medical doctors, you know, with some really very, you know, good background on the team. What have you been discussing and what have you been proposing as, you know, additions or alternatives for government to beef up what it does?
I'm sure you are aware, and I'm sure the media is aware, that we had put together 2 documents on what we think the government should do as complementing government's efforts. 2 very clear, we submitted to government. And unfortunately, we've not received any formal response, but we are happy that they have it. The former president, His Excellency John Dramani Mahama, has made some recommendations and suggestions as well, including the concerns about the water, rent, and electricity, and also advocating for certain protocols to be adhered to strictly in terms of washing of hands, proper wearing of masks, and all that. These are one, the president's addresses was recommendations based on his observations. Ours were 2 documents that we sent. We are not government, so we can't have a plan. We can only have documents to supplement or to guide government. But I just want to make sure.
Catch your breath.
No. Let me make sure on this plan and strategy. What I'm asking for, it doesn't mean that they are not giving directives for citizens to adhere to.
We are dealing with it. We are dealing with 3 T's as a strategy. You haven't heard the president repeat it over and again. You just want it on paper.
I have heard the president repeated it over and over again, as you said, quoting you. But I'm asking, where is the reference?
What does he repeat? 3 T's. What does he say they are?
They are. I think it says testing.
It's tracing, testing, and treatment.
Yes. Those things, fine. But where is it in any document? Let us get the definition of those 3 T's, and let's read something. We have given them something to read.
Thank you. Catch your breath for me. And Kweku, so this is how far we have come. And all of a sudden, we were told that we had peaked. And people are waking up this morning and yesterday in the evening up to this point, feeling very disgusted, not knowing whether to trust the management process, that you say we had peaked when we had what number, and all of a sudden we have 4,012 on our hands. The suggestion was that we had peaked and we were to decline. We'll get the experts to deal with that. But how could, we have gotten it so wrong? That's if my understanding of we had peaked and declining is correct.
Well, we did not get, to begin with, good morning to viewers, and good morning to you and my friend here. To start with, we did not get it wrong, and I will take some time later to explain what Dr. Bedusa Kodie, I'm sure that's the one you're referring to, what he said. But if you provide me the opportunity, I'd like to just make some brief comments to some of the issues that were raised. We can do better. That was his response, which I thought was a dignified response to the question you asked. And we agree. As a government, we can always do better. And it is a reason we're always having internal discussions, engagement with the experts to see how we can continually improve the way we are handling this pandemic. So we don't disagree with you on that. And when you said that, I got the impression that, yes, you're doing well, but you can do better. But what followed was, in my opinion, not really helpful. But, Sammy, maybe this kind of question you don't put to politicians. Because if you put it to politicians, we are going to get the kind of response that we're getting. I think you can go out there and ask the experts and ask people. I have heard many people say the government handling of this pandemic has been very good. And they scored the president high marks. We have seen the assessment by the World Health Organization. There are many experts across the world.
I'm trying to actually be double sure about that, because I'm getting, some information that suggests that that particular, rating may not be exactly the way it has been reported. But you go ahead.
That is
by the World Health Organization.
Yeah, that's my understanding, that we have handled it well. We have all seen that. So, as I was making the point, if you ask a politician who interprets any credit to government in an election year may lead to some advantages for government electorally, we are definitely not going to discuss the crisis we have. People are thinking about electoral advantage. That is how I see some of the points that have been made. Look, if you want to see the strategy of government, you need to look at the various instruments that have been issued, the various communications that have come from the president, and then in addition to the measures that have been deployed, the tracing, testing, in fact, isolating and testing has led government strategy in this area. And as the president has said again and again, we are relying on data and on science. That is what is leading government's approach to fighting this. And I think if you would look at what I've suggested to you, you'll be left in no doubt that government strategy for dealing with this is clear. I think it's clear to a lot of the population. I don't know, maybe you want all the instruments to be assembled. You want videos of the president's communication to us to be assembled and everything put together and presented as a strategy. It can be done. But don't give the impression that somehow we have been acting in some ad hoc way and that there's no strategy. I think it's a wrong view to take. But what I would say to my colleague is that it's very difficult to wake a person that is pretending to be asleep. It's very difficult to wake them up. If people look at what government is doing and they are minded to be uncomfortable because of what they consider to be electoral advantage, it's going to be very hard to convince them. I can rally all the things that I mentioned and give it to you as a strategy. You will still have ways to doubt that. So it is not something that I think we should worry our heads over. Before I quickly go to deal with the peak point made by Dr. Bedu Sarkodie.
You may deal with that briefly because we want the experts to focus their attention on that.
You also spoke about economic strategy. Maybe this is not a place for it. We may have time, so we all discuss exactly how government is dealing with the economy alongside ensuring that this does not get out of hand.
But look at things this way. Last week I asked Dr. Abuaje on the show, and he admitted the kind of lack of proactiveness, if you like, that has accompanied some of the protocols that are rolled out. Before the lockdown was lifted, why could the management team not agree on making mask wearing compulsory, roll out the plan as to the specific, if it is legislative or whatever it has to be, before the president would do the announcement? The president did the announcement, and it took a week before advocacy repeatedly got the Ghana Health Service to issue a statement telling people how to wear a mask and making it compulsory. Well, we are being told by the same Ghana Health Service again that it is now, how many weeks after the president said that wearing a mask is central after the lockdown is lifted, that it is now that barbers, you know, dressmakers or people owning saloons and the markets are going to be taught how correctly they ought to use a mask?
Samson, even before the president lifted the lockdown, I had many statements and communication from the experts and from the Ministry of Health and Ghana Health Service advising us to be using these masks. And in fact, advising against fake masks being produced. And let's not give the impression that it was after the president's statement that we started discussing masks. But I do appreciate the point you make, that indeed, perhaps if it was a law that was required, we could have done something like that before the president issued a statement. But if you remember, when the president issued his statement, he did say that the Ministry of Health will come out with the necessary, because some of these things would require some engagement. The
president spoke on Sunday. It was only on Saturday, from that Sunday, only by Saturday, that the Ghana Health Service issued the directives regarding mask wearing.
I am not in a position to explain why that delay happened. We may want to speak to the Ghana Health Service to understand why we had that delay. But the point I am making is that even that 1 week gap, or the period before the president came out with the lifting of the lockdown, mask wearing was already being advised by government.
No, the government had not. The government had not begun to talk about the mask wearing. It took the president to commence that process and to bring that effectiveness. It was after the president announced it that it became the biggest issue to discuss.
Yes, I agree with you. After the president announced it, it became the big issue. And perhaps it is good the president announced it. But there's no way you're going to say that until the president announced the lockdown, nobody had heard any advice from any government official that we should wear these nose masks.
Government had not, no government official or government had issued any directive or any statement asking Ghanaians to wear masks.
Well, we can go on with this disagreement. I think viewers would check that for themselves. I saw many people wearing masks in town, even before the lockdown was lifted. I saw, when I was traveling to my constituency after Parliament went on recess, there were people wearing masks, there were police people wearing masks. I don't know how that happened, but I'm just making the point that it is wrong to assume that mask wearing started after the president's statement, and that before that, some arrangement should have been made, whether legislation or should have been made before. I'm saying that the Ministry of Health could answer why it took the 1 week. I don't have immediate answer, but let us not give the impression by that the wearing of masks was delayed or that some irreparable harm has been done. I just want to say that going forward, we should act more quickly and more responsively.
Let me just put it.
No, wait. No, please wait.
So the summary. I think the Ministry of Health has now come out with the guidelines. The important thing is that we continue to drum home these guidelines to encourage people to get the right masks, to encourage people to use these masks. Government is putting out as many of these as we can, and maybe we should take that and move instead of looking back and suggesting.
So after the president made the announcement, because there was the delay in bringing out the measures and actually making it compulsory, even the police, there were reports all over that they had a difficulty enforcing it. As we speak, of course, there is a directive making it compulsory, but there are no criminal sanctions, and I'm not saying everything must come with criminal sanctions. There are no criminal sanctions with it. You don't know how exactly they can enforce them properly. But tie into the question of maybe lack of proactivity, because he has some concerns and he may have raised them in a certain manner, but you must admit that at certain times, certain things may have been done in ways that could have been done a lot more better.
I have already conceded that the people working in the Ghana Health Service and the Ministry of Health, they are human beings. So we cannot say that they are perfect. But you must look at the overall approach and responsiveness and see whether they deserve commendation or we should criticize them, people sacrificing so we can all fight this disease. Whether our attitude to them should be commendation or our attitude to them should be just chastisement.
The shambolic nature of the feeding program, giving out food packages and the rest of it, which actually threatened, you know, and provided sort of a fertile ground to create fertile ground for the spread. So from what he's saying, certain things may not have been done well.
Look, I don't know how many times...
And maybe you don't have a script that you are looking to implement what you are doing. That's why this is happening.
Look, if you make a decision that there is a lockdown and people are hurt economically, so you want immediately to support those people, and you're going to distribute food, and the population coming for the food decide to rush for the food, let's not pretend that you are always in a position to have done this any better. It's when these things occur that you now want to change strategy. But definitely the food must go. And we all encounter that all the time. What we should not do is to begin to make it look as though maybe the decision to distribute the food itself was bad, or that unless you devised a strategy to distribute the food in a way, maybe send it to people's homes, which would have required a lot of infrastructure, a lot of arrangement. You need to make decisions in these difficult times. And therefore, if it comes out the way it did, the important thing is to improve it. I mean, when we say shambolic as though somebody was just reckless, I don't think it's helpful for the discussions at all. I repeat, the Ghana Health Service and those managing this pandemic for us have done well.
Okay.
They are not perfect. They have got it wrong at some points. But they got it wrong because they wanted to help. In the process, if they make mistakes, we're happy to point it out to them. It should be done in a spirit that say, you're doing well, but if you can fix this and this as well, it will be helpful. That is the attitude I take, and I commend government. Maybe because I'm part of government, I commend the president for the way we have handled this. The frontline workers, the Ghana Health Service, they have done marvelously well. Look, a lady told me that he's surprised to see this in Ghana because she traveled. The address she gave was her family house, and it was because that was she immediately remembered. And when it turned out that they had to trace her, they went to that family house in Koforidia or so. Then they gave the health service where she must be now. And then she was there when they came and said, this is why we have been following you. We went to the address you gave. And he says, she was just amazed that in Ghana we could be this competent.
There's a contact tracing.
Yeah, the contact tracing. Okay. So please, I'm saying that there could have been slips here and there. But overall, I think the health service people deserve commendation.
Right.
And let's not give the impression that they have done a bad job.
Well, what do you say to those who also say to part of his point about the management? Before the lockdown, the announcement of the lockdown, the manner in which it was announced, gave room 48 hours or so for people to decide to leave the urban areas. People were traveling all over the place. So you announced that there should not be movement. But before it kicks in, there is so much time for people in infected, jurisdictions to move and to travel all over the place. Some say that could even be perhaps the reason why some other places began to get infected, even though we do not have data that suggests that somebody traveled from this infected area and went to infect another place.
You need to remember something, that the management of this COVID-19, as the president said, is being led by data and science. You don't have time. You're weighing the consequences of a lockdown on the lives of human beings against the risk and what interventions are needed. Look, sometimes I feel sorry for our cabinet ministers because they are attending meetings almost every day. Anti-COVID-19 meetings are going on in the president almost every time. The experts are going there almost every time. Things are moving very quickly because while the president is careful to ensure that he does not announce a lockdown prematurely, because it has cost to people's lives, it has cost to the economy as a whole. So he's just waiting to get it just right. Once the data and the science advised that, look, we have come to a point where there has to be a lockdown, the president has to make a decision how much time I'm going to wait for the risk of infection to manifest before I announce this. The president said 48 hours. I think even if a longer time would have been appropriate, in the circumstances, it was the best that could be done. And again, let us realize that these are human beings dealing with this.
All right.
And when these things come, we just have to look at it and improve.
Let's go to our experts who are with us on Zoom. And I must repeat that the report attributed to the World Bank, the World Health Organization about the Ghana's ranking still cannot be confirmed as accurate from the WHO. The Deputy Health Minister, Okoboy, had an interaction with the leadership of the WHO, and after that, he spoke and gave that indication. And then the publications began to run around about Ghana being in that position. So that's how to put it more accurately. Yeah.
I'm sure the WHO, if they did not agree with this position, would have issued a disclaimer.
The minister would not have. They would have issued a disclaimer.
Yes, the minister would not have done that, and they would have issued a disclaimer.
Let's wait and see if they do so or they don't. So. Okay, thank you. Now let's go to the phones and begin with go to Zoom and begin with Dr. John Amwesi. Thank you once again. Now, listen to this. Listen to Dr. Insiansare and listen to Badusa Kodie.
To 4th of May, that's yesterday, U.S., the mighty U.S., has 1,035,353 cases and 55,337 died, which means that their positivity rate is about 5.34%. If you come to Africa, South Africa, who is also tested, South Africa has tested nearly about 150 or 160,000. In fact, after South Africa, we are the next who have tested in raw numbers, more than anybody in Africa. South Africa has 6,336 positive cases, and 123 have lost their lives, which means the positivity rate 1.94%. Nigeria has 2,388 and 85 lost their lives, so positivity rate about 3.6%. Ghana has 2,719 and 18 have lost their life, so the the mortality rate for Ghana is 0.66%, less than 1%. If you look at all the countries, in fact, the only country who have tested, and I'm sure they've tested only very few patients, that's Rwanda. We don't know the number that they've tested. They have 259 and they have no deaths. Ghana's mortality rate is 0.66%. So if you look at the dynamics, it means Ghana, in Africa, and almost in the whole world, we have one of the lowest, according to the number of tests that we have done, because we have done a lot of tests. So what it means is that in Ghana, the dynamics of the disease is quite different, even from the whole of the African sub-region. And for the whole world, our dynamics is quite different. That is because of the good measures that we put in place at the initial stages from the 15th of March till date. It doesn't mean that we are out of the doom. And if you look at even the numbers that we have, those who are well and responding to treatment, out of the 2,719, 88% of those people are well and responding to treatment either in the facilities or in isolation or at home. Somebody will ask, why is it that we have so low recovery rate? and discharge patients. That is something we are doing in process. If you look at it, if you even look at the first few cases that you have, some of them are not in the country, but I'm sure they are all recovered and discharged at wherever they are. So we are gathering all these figures, and very soon we shall tell you how many people have been discharged or recovered out of, they don't have the virus and has been discharged. It doesn't mean that we are out of the doom. It means that we have to continue whatever measures we have put in place. What it means in Ghana is that we are lucky. We took a lot of measures early enough. So we should be very grateful to the Commander-in-Chief, His Excellency, the President, for putting in these measures, which has a lot of social and economic problems, but he took it.
We started having a build. The first confirmed case in the country was on the 12th of March. Since then, those were from the people that we put together later, those that were put on quarantine. Out of the 1,030, within a short time, we had 115 of them. Those in quarantine at Accra here and also in Tamale. So we realize that with a sharp rise, and now with the cases that we are tested, clearly we seem as a country to be on top of the peak, and we are at the stage to decline. That is the observation now. The declination will depend on how we adhere to the various preventive etiquettes that have been enumerated. We are not off the hook yet, but then if we continue the way we are doing now, by adhering to the various social distancing, adhering to the various individual preventive measures, wearing of mask, keeping away a distance from others, hand washing, cough etiquettes, other respiratory etiquettes. These are the things, when we do intensively, will let us come down from where we are. So responding directly to the question, where we are at the peak of the curve, yet to come down. But then the only thing to make us come down by strict adherence to the various preventive etiquettes.
Dr. John Amwesi, how did you understand the Director of Public Health at the Ghana Health Service, Bedusa Akodie?
Thank you, Samson, and good morning to your listeners. Samson, if you'd allow me some time just to try and build the picture, because to be able to put my comments in context, I need to bring your listeners to a certain place. Again, I've always maintained, and thank you for having me again, that we will complement when it is necessary, and when we need to critique, we will also do so. This is the least that some of us as academics and independent scientists in our institutions, and I sit at the KNUST, can do. Now, it is clear that as of today, Ghana has just about the highest number of cases in West Africa. Now, this needs to be taken in context, because it's possible to have many more cases than your neighboring country or a country of similar socio-demographics, and yet have less deaths. And this is a very important thing to know. In Ghana, we have about 4,012 cases so far, some have recovered, and 18 deaths, 754 recoveries. If you look just to the west, you have Côte d'Ivoire, and in Côte d'Ivoire, you have 1,602 cases and 20 deaths. So that's 2 more than Ghana, but you know, the proportion is much higher if you should do the math. 323 recoveries. In Nigeria, very close to Ghana, but a much bigger country, 3,912 cases and 117 deaths. Now, this is the West African picture. You can look at the same picture and how it's panned out in Europe, for example, in Germany, where you have 170,000 plus cases and just around 7,000 plus deaths. On the other hand, very similar number in France. 176,000 or so cases and 26,000 deaths, almost 3 times. So this tells you that you can have countries that may be very similar, very close to each other, and you may end up with very different pictures. Similar pictures with respect to numbers of infections, but very different pictures with respect to death. The fact that we're seeing much less deaths in Ghana than even our neighboring countries should tell you that we are doing something right. I think that every expert would agree on this. We are definitely doing something very right. Now, it's important that we do not focus on the number of cases going up. When I say do not focus on it, what I mean is it needs to be taken in context, because it is actually a good sign. And you need to allow me some time to explain why I say this. It's a good sign because the more testing you do, especially the kind of testing we're doing, which is the targeted testing, the more the cases you will see. So we have taken an approach which is more about seeking out who might have the disease, which is the targeted surveillance, and it has a huge influence on the prevalence that you will measure. So the question is, who are we testing? So it does not necessarily matter how many people you are testing, but who these people are, where they are. And we have focused on testing those who are potentially exposed. It's therefore not surprising that you will get a good number of positive cases. But what has borne out for us in this approach, what has helped us in this approach, is that we have had much less deaths. So it is because we are actively looking for those who might be potentially infected, you're able to get them earlier, address their illness, and ensure that they do not fall, terribly sick and therefore die. So it's very clear. You see the picture. We have less deaths because of our targeted approach. But what is happening in many other African countries is that they are really focusing on those who are presenting as being sick. They test them. And so you end up with the number of infections appearing much smaller, but then you have a higher percentage of people dying. And this is exactly what you're seeing. So the question is, how can we keep up with our enhanced contact tracing approach or our targeted surveillance approach as the infection continues to spread and more people become invariably exposed? So it means you cannot, maintain the approach that we are taking for now. It's the best approach in the interim, but moving forward, we need to change gears and we need to change fast. We did what we could do because we had limited tests and limited testing capacity. But we need to change those gears really, really fast. The reason is that we will otherwise lose the gains that we have made because we will no longer be in a position to catch people early, because there'll be many more people who have the disease, and the disease will start moving faster than we can, and we'll end up playing catch up. Now, I'll explain regarding the peaking issue. So what's happening, as I said, is that we're detecting more cases, but then we're telling people that these cases are on account of the expanded surveillance and not the expanded epidemic spread, when in fact we are not measuring the spread. So this is where I, as an academic, get a bit uncomfortable, because we are in fact showing just one part of the picture, which is true, and maybe perhaps turning a blind eye to the fact that we do not know what the other part of the picture looks like. And the fact is, or the painful thing is, that time will always reveal the true picture. So I see this akin to the proverbial story of the blind man and the elephant, where one will be holding the tail and saying it is a rope and professing strongly that it is a rope. And so we have one part of the story, and we have provided evidence that is almost incontrovertible to that part of the story. But we need to be clear with the fact that there is a bigger picture. And we cannot keep speaking to the rope part when we know very well there's another part that we just happen not to know now, because we are not measuring it. We're not measuring the actual rate of spread of the disease. So the curves that were presented, I'm now getting to the peaking issue, right, is actually the curve that is based on the results of our largely expanded targeted surveillance. So the question would be, what peak are we talking about here? All right. So we are presenting a peak which is actually reflecting numbers from our expanded surveillance. It is not reflecting the rate of spread of the disease. You want your peak to be based on your measurement of the rate of spread of the disease. When that is sustained, and then eventually you have a reproductive number, the R naught, which you've heard so much about, dropping below zero, that is when you would have eventually a decline. So to sum it up, what I'll tell you, Samson, is what has been presented is a certain type of peak, but it is only the peak of the picture from our expanded surveillance. We are not measuring the spread of the disease. And therefore, we are not able to tell what the peak of that spread is and where we'll be going from there.
We cannot say that Dr. Bedu-Sarkodie was wrong about this. What is a peak? What is the standard definition for the peak? And, you know, people, including Kwame Sapong-Asiedu, have said it is a mathematical definition. And that definition is when your daily recoveries are more than your daily infections. So this graph, which tells us about advanced surveillance and, you know, samples that were taken long ago and don't get, you know, results within the same day, and to on that basis say we have peaked and expect to decline. Will you say that was a mispronouncement on the part of, you know, the team?
Samson, I think that's a great question. And let me come back to what I was talking about, which is the presentation of the picture. So the picture was presented by the Ghana Health Service, which I must say is an accurate picture based on what they have available and what they set out to do, which has been this enhanced, you know, tracking, testing, and treating. And when we speak of a peak in epidemiology, and I can tell you because I teach this as part of my work at KNUST, you can have many kinds of peaks. You can talk about the peak in terms of the rates of death. You can talk about a peak in terms of the rate of infections. You can talk about a peak in terms of rates of recovery, and in so many other ways.
What did we understand? What did we understand Dr. Bedu-Sarkodie to say in this regard? What sort of peak did he speak to?
I'll tell you what it is. I'll not tell you what he said. I'll tell you what it is based on the graph because I can interpret it. And what I'll tell you is that this is reflecting the picture of those who were contact traced, those we have actively surveilled and looked out for to a large extent. And this picture is only showing these kinds of people. We have not, and I stress again, we have not measured our rate of spread of the disease.
Right.
And really the most reliable kind of graph that you want for which you can begin to speak of a peak and talk about a decline eventually in your infections is in relation to the rate of spread of the disease. And this is when you want your reproductive number to go below the 1. This graph does not give you this information. And the comments that he passed regarding the peak were comments on this graph.
Okay. Let me bring in Kofi Kwache also to understand what his appreciation of this question of the peak, and that's such an excellent, you know, explanation you have given, very easy to comprehend from a layman's perspective and to work with. Now, Kofi, from where you sit, what are we doing wrong by this kind of projection of a peak, if we are doing anything wrong by that?
Okay. Good morning, Samson. Good morning to your esteemed panelists in the studio and to Dr. John Amoasi, an academic who I actually follow quite closely. I think when it comes to the issue of the peak, what the data that was presented, like Dr. Amoasi said, has to do with the amount of positive cases we are detecting over time, which itself is a function of the number of people we are testing over time. That's why it feeds directly into the question of the enhanced contact tracing. Now, again, that does not give you a full picture of exactly what is going on. The reason why the basic reproduction number is an interesting or it's a key variable really is because that is actually what determines how many new cases you have. And to actually track how the epidemic is progressing, what you're really looking at, the actual outcome variable ultimately you're looking at is how many active cases do you have per day. And the number of active cases you have per day is a function of the new cases you have, subtracting from that your recoveries and deaths per day. Now, if your reproduction number is slow, it means your new cases will come up slower and your recoveries will catch up with that or even supersede that over time. So you will start to see that when you do a histogram of your active cases per day, because the recoveries are outpacing the new cases, you start seeing the decline. So that classic kind of epidemic curve that we've been looking at, that bell-shaped curve, that's actually the outcome variable that we are looking at, the active cases. The basic reproduction number feeds into that because that's what determines the number of new cases you're getting. And then your management of the cases is what determines your mortality and your recoveries, which is how you get your active cases. Looking at just the number of new cases you get per day, while also ignoring the number of tests you've done, cannot actually tell you that you reached a peak. That's not how it works. And it's not possible also to conclude that you are approaching your peak if you're not seeing certain characteristics in the actual curve of the active cases. What you want to see is that you are having a deceleration over time leading up to your peak, so that over day by day, you are seeing a smaller percentage increase in your active cases. That lets you know that you are decelerating and approaching what could be a peak. But most countries don't even know they reached a peak until they've passed it, because that is the nature of the data analysis. You have to pass it, observe over time, and then say, okay, now that we've studied the dynamics of over maybe 3 or 4 days, maybe even a week, New York City, California, I know both looked at 2 weeks of data to make that conclusion. Then you can say, okay, now we have a situation where consistently the percentage change in our active cases is actually negative, and the percentage increase in our recoveries is going up. So we are getting a sustained downtrend. So we can say, okay, we have passed our peak. If you follow a lot of what's going on in Europe and the United States, that's kind of how the explanation has been made, that we have passed our peak. No one has really said we are at our peak or we are approaching our peak, because the nature of the data collection makes it hard to actually say that definitively. So especially if the insinuation from the graph that was provided was supposed to be that we were going to peak in terms of the pandemic, or the local epidemic here, then I think that was inaccurate. And it's important that that stuff be put in its proper context, because many people are evaluating their own risk perception based on those kind of statements. They are deciding what the extent of the threat out there is based on those kind of statements. So if we're not tight and very specific in our description of exactly what the key variables are and what they're telling us over time, the likelihood that the risk is that you're going to have people overrealize. I think we've seen that in some of the other issues. I think early on, a lot of the description of the epidemic was that it was a matter of imported cases who were tracking and tracing, which was true. In every country apart from China, it was a situation of imported cases. So if you're able to track the ones you are getting, trace them, test them, and isolate them, you would make some gains. But quite obviously, if you look at our data, for example, on March 20th, when we had 16 cases, 3 of them had no travel history and no confirmed contact with any infected person. So it was quite clear that even then we had local transmission going on. But framing it as a problem of travelers and importation can skew the perception in the general public about what the general local threat is. And one of the variables I look at where we are really is the routine surveillance cases, not just the enhanced contact tracing. The enhanced contact tracing, yes, it's aggressive, it goes out and finds people. But even then, it's a question of how you define the contact, like what Dr. Mwasi said. If you're not specific in the definition, you might bring in too many people who don't have epidemiologically relevant risk. But with the routine surveillance situation, what you're seeing there is people who have symptoms, who are walking into hospitals and are testing positive for COVID-19. And we've seen that number jump up almost 33% in the last 4 days. That speaks to the question that we have a significant amount of local transmission that our contact tracing effort is blind to, because the routine surveillance numbers are the people we don't expect to see. Those are people we are not expecting to pick up. So if we're seeing that the active cases there go up, there are many reasons why we should be concerned. One of them being the fact that the active cases there are actually clinical cases. They are symptomatic and need care. So if we don't get a handle of that stuff quickly by assessing broadly, like Dr. Mwasi said, what our actual local spread is, to have a sense of what the health system risks are, we might find ourselves unpleasantly surprised by very, very aggressive jumps in that particular category. And that's where, especially for me, in a lot of the analysis I do, I look at the routine surveillance data and map that out, because you can clearly see there, for example, that it's like what Dr. Marcy pointed out, because those are people who are coming in later on in their disease progression. That's where we've actually recorded all our deaths. We recorded all 18 deaths from that routine surveillance population. But ironically, we've also recorded all the recoveries from that routine surveillance population. So quite clearly, we are doing something correct when it comes to the treatment. But there's also factually something going on. There's something to acknowledge there about the fact that we're seeing a low mortality rate so far might also be a function of the timing of when people are being tested and showing up.
All right.
If you look at the average incubation period being 30 days, then there's a risk that what we are looking at right now is a time-specific cohort mortality rate and not a broader question. So we should still keep our guard up and be aggressive in tackling this issue.
So, Dr. Amwesi, Dr. Ampofo of Noguchi, the director, also at this press conference to update the country on what was going on, indicated that it was your place, your center, KCCR, that had 1,982 samples awaiting testing. That was the backlog. And that would have been cleared by Thursday, some 3 days ago. How do we explain the numbers that has brought our total infections to 4,012 when this backlog had been cleared by Thursday?
Well, thanks for that, Samson. And I just want to say thanks also to Nana Kwachi for that beautiful expose on the numbers and trying to explain what they really mean. Now, with regard to the numbers that we're seeing now and the backlog of KCCR, I need to also acknowledge the great work that is being done here at my center at KCCR, Director Phillips, Professor Phillips, and the testing team led by Dr. Michael Owusu and Dr. Augustina Silverkin, working day and night on this to clear the backlog. And KCCR is a much smaller place than Noguchi, so to be able to do the kind of work we do, we really need to put in a lot. But that notwithstanding, I am not directly involved with the testing because I'm not a virologist.
Right.
And I can tell you that, yes, the backlog has been cleared because this I confirmed personally with the testing team. There are pieces of information coming in from routine surveillance. There's information coming in from the enhanced contact tracing, which is still ongoing. And now when we talk about the enhanced contact tracing, you need to realize that it will include tracing of people who did not who came in contact with someone who did not necessarily have a travel history, which means that contact tracing does not end when we have been able to necessarily trace all those who traveled, because we will find someone who traveled, who passed infection on to someone who did not travel, who then passed infection to someone else who did not travel, and so on and so forth. So this will continue. So these the results from this kind of work will keep coming on and keep adding on to whatever backlog that we had. So until I have the fine detail of the numbers of how many were from an enhanced contact tracing, how many were from the backlog, how many were from routine surveillance, it's very, very hard for me to make any declarations or speak to the dynamics of the numbers. But Samson, I would encourage you to focus more on the interpretation of the numbers and the different categories of the numbers. And particularly what Nana talked about, which is what we're seeing regarding the numbers from the general surveillance, or what we call the in actual fact, it's a passive surveillance of some sort, really a passive surveillance. People who are sick, who walk in, who come in with complaints. If there's anything we need to focus on, this is it. And if the information that we have, which was provided by the Ghana Health Service regarding the 500 plus people who were infected from an industrial facility of about 1,500 plus people, that for me is exactly the reality we should be concerned about. Because if you have a workforce of 1,500 and something, and you have 1/3 catching the virus because they were exposed to someone who had it, that is the reality of what we are facing in our communities. And therefore, what we should anticipate is more numbers. Now, when I say anticipate more numbers...
Dr. Mwesi, I'd like you to hold it on there for me. We will come back on the question that you say, what has been discovered at the industrial facility is a reflection of the reality in our communities. What does that mean for our fight going forward? We take a break. We'll be right back.